formerly of KCL, actually, but she's now an MPhil student in the Department of History and Philosophy of Science at the University of Cambridge. Astrid's research interests are in philosophy of science, medicine, and particularly the relation to testimony, race, and gender. Astrid's talk today will be entitled Reducing Inequalities in Healthcare, the Importance of Educating Medical Personnel on Testimonial Injustice. So very welcome, Astrid. Really glad to have you here, and I'll hand over to you.
Thank you. I'll just see if I can share my screen. Can people see this?
Yeah, that looks great.
Okay, cool. Yeah, so today I'm going to talk about educating medical personnel on testimonial injustice as a way to reduce inequalities in healthcare. And yeah, so the main claim that I'm making today is that medical personnel should be educated on testimonial injustice and its occurrence in healthcare, as this can help reduce gaps in quality of care and in treatment of patients. What I'm going to do is first, First, I'm going to go over the concept of testimonial injustice, just so that I'll explain what kind of thing I'm talking about and what definition I'm working with. And I'm going to look specifically at testimonial injustice in healthcare. And then I'm going to explain why I then focus on marginalized social groups and how they are extra susceptible to testimonial injustice. And more specifically, I'm going to look at pain testimonies, that's reports of pains from certain patient groups, and how they can be sort of silenced and not taken seriously as a result of testimonial injustice. And then I'm going to look at ways in which we might reduce occurrence of testimonial injustice in healthcare. And I'll finish off with the conclusion and some qualifications to this. Okay, yes. So the concept of testimonial injustice is part of another concept or another sort of phenomenon which is known as epistemic injustice. So very sort of broadly, you can say that epistemic injustice is something that occurs when someone is wronged in their capacity as a knower, someone who has knowledge and can relay knowledge to other people. And so this concept was first sort of formally introduced by Miranda Fricker in 2007, sorry. And she speaks about two kinds of epistemic injustice: testimonial injustice, which I'll be focusing on, and which sort of relates to reports and testimonies, so like when someone is trying to share a piece of knowledge or belief with other people. And then hermeneutical injustice, which I won't be going into much detail about today, which broadly can be said to relate to meanings and shared sort of interpretations and understandings of certain concepts or lack of such concepts. Now, testimonial injustice is something that Fricker describes as an identity-prejudicial credibility deficit. And to sort of understand what this is, I think we should break down this long concept. So first, the first part of the concept relates to identity prejudice. And the way that Fricker sort of used prejudice is meant to be you can describe prejudice as something that can both be negative, positive, and neutral, and it's generally just a preconceived sort of opinion about someone or something. It can also be about a certain kind of research method is good. But then identity prejudice relates to someone and is a prejudice that sort of relates to a person's social identity or the social group that they're perceived to be part of. So sort of a more neutral example would be that, say that I'm at Temple Station and for some reason the district line is down, and I'm assuming that the person wearing a red and navy uniform is one of the people working at the station, and therefore I'm asking them, why is the district line down, and do we know anything about when it might be back in working? So because of sort of the sort of general sort of way in which we pick out people that work in London tube stations, I assume that this person also works on London tube station. Now, this sort of relates to then the second part of identity-prejudicial credibility deficit, which is the central case of testimonial injustice, because what you can then have is negative identity prejudice that result in what we call a credibility deficit. So Frigger argues that generally, and I agree, generally sort of we use consciously or unconsciously stereotyping every day in sort of more like varied degrees to evaluate how reliable people are, or like when they're telling us certain things. So this could be me sort of calling my GP and then assuming that the person taking the phone is reliable to tell me when I can get an appointment with my GP. So that's sort of a judgment of her credibility with regards to this matter. Now, what credibility deficit then relates to is when someone's testimony is sort of judged to be less credible than it is in fact, or we can say that it should have been evaluated as. So like a case would be, there's a sports event going on for children and a child hurts their arm, comes over to the coach crying. The coach says, "Oh, that's all right, it was just the hit and it's probably just a bruise." But then one of the parents attending takes a look at the child's arm and says it's actually likely to be broken. But the coach again dismisses this and say, "Oh, I'm sure it'll be fine for the next event." So in this case, the coach doesn't sort of judge that this parent is reliable to say something about whether or not the child's arm is broken. But what the coach doesn't know is that this parent is a medically trained person, right? So, and they have experience working in an A&E, so they are in fact rather credible in terms of making a quick sort of evaluation of what is going on here. And then what I sort of think is most interesting, and Frigger also focuses on, is then when these instances of identity-prejudicial credibility deficit maps onto sort of wider systemic social injustices and inequalities. So that would be like wider stereotyping. So say that this parent at the event is also a woman and is also perceived to be from a low socioeconomic sort of class, and part of why the coach dismisses her testimony, likely unconsciously, is that women and people of sort of lower economic classes have historically been stereotyped as unable to sort of access this kind of knowledge, or less rational, and perhaps there are remnants of this kind of stereotyping unconsciously impacting the way in which the coach in question evaluates how credible her testimony is. Now then, when we then look at healthcare, there are a couple of things that should be said. So it has been argued that patients generally, just merely because of their role as patients in the healthcare system, are particularly vulnerable to instances of testimonial injustice. So part of this is that patient testimony can be sort of called irrelevant, confused, overly emotional, inarticulate, and or taking up too much time. And this relates to sort of a wider aspect of why patients might be more susceptible to testimonial injustice, which is that, as Kathy also mentioned, most doctors work on quite tight time constraints, and there isn't a lot of time to engage with specific patients, so maybe there's an increased sort of tendency to rely on stereotyping in our evaluation of how what is important that the patient says, and how reliable the patient is to say something about specific matters. And then additionally, there is sort of the doctor and nurse and like other medical personnel is in a different kind of authority position with regards to knowledge of medical issues, which means that there is sort of an asymmetrical relationship between patient and doctor. I mean, this is not just like, bad, because otherwise, if this wasn't the case, we wouldn't seek the help and assistance that we do in healthcare. So it is kind of warranted, but in some instances, it might be exacerbated, and it can also feed into sort of patients being sort of silenced and not sort of considered a person that can equally contribute, or at least has something valuable to contribute to the diagnostic care and treatment process. Now, another aspect of testimonial injustice in healthcare is sort of testimonial injustice, which disproportionately affects groups that are already marginalized in wider society. So this would be, say, like groups of non-white people, or people from sort of depraved areas, and certain people with who are not heterosexual and sort of related. This is just some examples, but that means so it's not just in the setting of healthcare that they are vulnerable to testimonial injustice, or to whatever they're saying being sort of given a deficit in credibility as opposed to what is actually due. It can also happen in sort of teaching settings or research settings, or generally just if you see them on the street and want to ask them something. And this in turn can sort of result in them experiencing a lower quality of care and treatment, as opposed to groups that are not from such marginalized groups. Yeah. And sort of my reason for focusing on these groups in specifically, or like groups that are also already sort of marginalized or experience it in other areas of society, is that there are loads of sort of research and studies indicating that there general inequality in health and healthcare that track certain lines of sort of social inequality and marginalization. So one example is some disparities in sort of birth and pregnancy related mortality rates. So between 2014 and 2016, Black women were found to be 5 times more likely to die in pregnancy than white women. And in 2014, infant mortality rates amongst sort of people from the Pakistani, Black Caribbean, and Black African ethnic groups in Britain were much higher than amongst white ethnic groups. And additionally, sort of, there's been research suggesting that it's not just sort of the outcome, which might also, well, definitely depends on other factors than sort of the patient practitioner encounter, such as general socioeconomic conditions and genetics to some extent. But there's also an inequality in relation to how people experience the care that they receive. So Bone and others have identified that with regards to gender, ethnicity, and age, there were differences in how certain cancer patients in the NHS experienced the quality of care that they received, where women and non-white people and younger people generally rated their care as less good than other people. And then it's also been suggested that there is sort of a link between patient experience of care and then practitioners harboring sort of implicit assumptions about a patient's social group or social identity. So that would be negative identity prejudice. Yeah. So then one sort of instance where patient testimony seems to be very crucial is in relation to reports of pain. So it's like the presence of pain and also the intensity of pain. So it sort of the Institute for sort of the advanced study of pain has described sort of patients' own expression of pain, verbal or nonverbal, as the gold standard for establishing sort of the presence of pain. And this is because sort of pain is a first person experience, it's very subjective. I can't necessarily say if the person opposite me is in pain or not. And it's also not necessary that there is any sort of tissue damage which could potentially be identified by another person as that accompanies experiences of pain. Now, sort of what's interesting is that I'm here going to focus on non-white people because historically they have been stereotyped as infantile, insincere, and incoherent, amongst other things, in various sort of contexts, countries, and times. And while I hope everyone agrees that this is in fact not the case, these sort of stereotypes are perhaps still sort of impacting the way people evaluate testimony of pain. So if we look at three cases, the first is from the 1950s, French Algeria, where Frantz Fanon has described sort of the way the French doctors related to Arab Muslim patients in the country. Specifically, the Arab Muslims were stereotyped as insincere and inferior in intelligence to white people. And when they reported pain, the doctors tended to either say sort of, this is a lie, or they found them totally sort of incomprehensible. So this resulted in the Arab Muslim patients, in fact, not reporting pain and not seeking healthcare, right? So didn't get the care that they needed. And then so another case is, it's called Susan's story. Susan is a fictional name, but it is based on a real case. So it's from the 2000s Australia. And so Susan is a woman from a low-income Aboriginal community, and she's experiencing quite severe abdominal pain, and is presenting with this pain at an emergency room. And even sort of upon being admitted to the medical ward, when she's saying the pains is sort of, can I get some pain medication because this is quite severe? The nurse, she describes how the nurse is quite hesitant to prescribe this pain, first because she accompanied sort of early in the week her brother to the hospital because he had broken his arm, and then likely because in that particular context, the sort of Aboriginal community is stereotyped as sort of low income and more likely to be sort of addicted to painkillers or opioids. Nevertheless, Susan does in fact experience quite severe pain, and like later on ends up vomiting blood, right? And then additionally, there is a sort of aspect which is that the way the Aboriginal community in this case talks is different from that of many non-Aboriginal Australians, and therefore Susan's sort of very sparse use of words is considered to be sort of suspicious. Now, another case is sort of more contemporary, and it's from a study published in 2019, and it's done in the US. So it focuses on Black and Hispanic mothers' postpartum pain scores and how this is managed. And so sort of a survey of almost 10,000 mothers from various races of ethnicities, it sort of showed that Black and Hispanic mothers were not only more likely to score their pain as more severe than white women, but at the same time, they received less medication for the pain than white women. So there is a significant gap in terms of like, at least like pain scores, and pain medication did not correlate when it came to Black and Hispanic mothers. And this was both during hospitalization and post-discharge. And what sort of these cases all have in common is that we have incidences where people are wronged in their capacity as knowers, and here it's about knowing that you are in pain and to what extent you are in pain, or the degree to which this pain is affecting you. And then what sort of the results of how these sort of testimonies of pain is not taken seriously is that there is certain information that is relevant to diagnostics and treatment which is missed, and this impairs these very processes. And additionally, we have people from marginalized social groups that are sort of not experiencing a good quality of care, and this may result for various reasons in the breakdown in trust between patient and practitioner, and patient and sort of the whole wider healthcare system, which may further result in patients from these social groups not seeking care in the first place and becoming very ill as a consequence of this. Now, what can we then do is a why, or like, it's a very interesting question. And so testimonial injustice as a concept was, of course, first formulated in sort of philosophy context, and philosophy is not an empirical science, but there's been some suggestions or proposals as to how to sort of limit or eliminate or decrease sort of incidences of testimonial injustice. And so Fricker, in her original work, writes that we want to have or move towards creating virtuous hearers. So, and the virtuous hearer neutralizes the impact of prejudice in her credibility judgment. So she realizes, here I might be prejudiced, or some negative identity prejudice might impact how I'm evaluating testimony, and tries to make up for that. But that is sort of perhaps easier said than done. And then there's been some further suggestions as to how to deal with not just testimonial injustice, but also sort of epistemic injustice, and a kind of unconscious stereotyping or perhaps implicit bias that is very closely linked with this kind of injustice. So one is a phenomenological toolkit, and then we have also trying to control stereotyping in a way which still sort of, as Kathy mentioned, remains sensitive to good kind of generalizations with stereotyping in medicine. And then there's also trying to sort of instill a habit in medical students and nursing students, and later on healthcare personnel, of pursuing egalitarian goals when they're approaching sort of groups of patients that are more likely to suffer from this credibility deficit as a result of identity prejudice. And this, they argue, can be done, or propose can be done, over a long period of like case-based learning, and just like practicing, so that it becomes chronicle, in that it's not in the end, it doesn't take a lot of effort to sort of be a virtuous hero. And one common feature, which is what I'm gonna use in my conclusion is of these suggestions, is that there is an idea of like at least teaching practitioners and healthcare personnel about testimonial injustice and or sort of unconscious stereotyping in healthcare, making them aware that this is something that happens and what it is, and that especially in healthcare, we might have sort of like patients may generally be susceptible to testimonial injustice, and we might also have social groups that are sort of double harmed or like experience a twofold of testimonial injustice, both because they're patients, but also because they come from marginalized social groups. So yeah, this is why I'm concluding very sort of tentatively, I guess, that medical personnel should be taught about testimonial injustice and its occurrence in healthcare. And I think this is sort of something that should be done or begin already from in sort of the initial education, so during university education and training. And it's not just satisfactory to have one designated session on the topic, but should take place sort of over a longer period of time. And I think so. Generally, I think teaching medical personnel about testimonial injustice can help lessen the occurrence of this kind of injustice in healthcare, and in turn may reduce, or is likely to reduce, inequality in sort of the quality of care and patient experiences sort of generally. Now, there's like a couple of qualifications that I would like to make, and so this is not an argument for the claim that this will then sufficiently or be sufficient to eliminate sort of all disparities in quality of care and experiences of care and social inequalities in healthcare generally. I think this is one small step in doing so, and I think there are other also very promising ways in which to both reduce testimonial injustice and improve patient-practitioner communication over time, but also to reduce inequalities in healthcare generally. And then, so for example, one other commonality in some of the suggestions is there's an emphasis on time, right? So maybe assigning more time for personnel to interact with patients. There's some structural concerns here and some economic concerns here, but I think, so there right now, there's been a report or book published in Denmark that suggests, so this is focusing on treatment of non-white migrants, and suggests that although you sort of give more time to a single patient initially, it doesn't, in the end, resources will not sort of increase, because it means that the patient doesn't have to continuously come back with something that was not treated in the first instance. Yeah, but yeah, that's my talk.